Good afternoon, everyone. It is 3:01, so we will call to order our monthly Treatment and Recovery Subcommittee of the Nevada SURG to order. Before we proceed with roll call, I wanted to make an announcement that Assemblymember Heather Golding has joined our subcommittee, and I know she's with us here today. So very excited that she's going to be on the subcommittee with us. Assemblymember Golding, not to put you on the spot, but I don't know if you want to make any remarks before we get started.
Just to say, I'm absolutely delighted to be here. Thank you so much. I'm looking forward to learning a lot.
Thank you. We're so glad to have you here. Okay, so next item of business is to do our roll call. So I will turn it over to Kim Hopkinson to do roll call and establish our quorum.
Thank you. All right, so when I call your name, please indicate if you are present. First up, Member Cheatham. I don't believe that she is on the line. Dr. Dixon?
Here.
Dr. Dixon. Member Edwards?
Here.
Thank you. Assemblymember Goulding?
Here.
Okay. Member Iverson? All right, and Chair Shell?
Here.
All right, so by my count, we have 1, 2, 3, 4 out of 6 members in attendance, and we have quorum.
Great. Thank you, Kim. Moving on to item number 2 on our agenda. This is for discussion only, public comment. Please bear with me as I make a brief statement before we open it up to public comment. Public comment will be received via the Zoom meeting. Public comment shall be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which may be taken pursuant to NRS 241020. So on that note, I will open it up to public comment. Do you see anyone, Kim, wishing to make public comment? I'm not seeing anyone.
I do not see anyone at this time with their hand raised.
Okay, so that will conclude public comment. We will move on to item number 3 on our agenda. This is a review and approval of our meeting minutes for May 22nd, 2025 for possible action. Hopefully our subcommittee members have had a chance to review those minutes, and if so, we can entertain a motion to approve.
This is Dr. Dixon. I'll move to approve.
Thank you, Dr. Dixon. Do we have a second?
Dorothy Edwards, I'll second.
Thank you, Dorothy. Any discussion regarding the minutes for May 22nd, 2025? Hearing none, all those in favor, please say aye.
Aye.
Aye. Any opposed? Motion carries unanimously. Thank you. Moving on to item number 4 on our agenda, we're very excited to have Mr. John Hamilton with Liberation Programs with us today. He is going to present on a proposed recommendation that came from our member Chelsea Cheatham. And for those of you that may recall, her proposed recommendation is a retrospective assessment and a prospective study would be conducted to assess the outcomes of patients following discharge from detoxification and examine mortality and overdose. So on that note, I will turn it over to Mr. Hamilton. So glad to have you with us today.
Thank you, Steve. I'm honored to be here. I really appreciate it. And I sent Kim, I think, about 4 iterations of some slides, but I think I got this one right for what you're looking for. Again, I'm John Hamilton. I'm the CEO of a large behavioral health agency in Connecticut. And I also chair the state advisory board for the Department of Mental Health and Addiction Services. And I've sat on a lot of national committees and the dissemination committee for the National Institute of Drug Abuse. I had the honor of putting together the first voluntary treatment system for the Republic of Vietnam and have done work around the country. But specifically today, what I'm speaking of is something that came to us from a study from Dr. Robert Heimer, Dr. Gail D'Onofrio, and Dr. David Feline, who is a pioneer in the field of buprenorphine, physician-based buprenorphine. And what came out of that study was our look at overdoses in Connecticut, 2016 and 17. And I have a slide to touch base with it, but I'll get right to the point. When people leave detox and a residential treatment and they are not connected to care post-discharge, they actually have a greater risk of dying of an overdose than if they hadn't gone to detox or residential care at all. So it's that iatrogenic effect of treatment, right? Somebody goes in for a broken leg at the hospital and they die of a staph infection. This is pretty similar. And I just feel like I have to shout it on the rooftops. And I had the privilege of sharing it at a national conference at the RX Summit in Nashville. And people seem to be responsive of it. And the sad thing is, around the country, people have gotten back to me, said, yeah, we know that that's the case, but it's great to see Nevada actually going to do something about it. So I'm very impressed, and you are all very progressive for even addressing this. So I don't know, Kim, if you're you have the slides. There we go. Just
I do have the slides. Please just prompt me when you'd like me to move it forward.
So this just gives people probably aware of this is kind of an understanding when we talk about treatment and prevention. My agency actually does prevention, treatment, and recovery. We're in harm reduction. So I see it all as prevention, preventing the vulnerable brain for kids and universal prevention on the front end, and then preventing death and relapse on the back end, because we know only 1 out of 10 individuals will actually seek treatment out in the country, not just in Connecticut, but pretty much consistently in the country. Only 10% of individuals who would benefit from treatment seek out treatment, and the other 90% we are trying to engage in keeping them alive. So it's either prevention, relapse prevention and recovery management, or prevention of harm and death in our work. So what I did there is to have that overlay as the health promotion strategy, which again is just the emphasis that detox is just a good beginning. And detox alone, as shared by Dr. Walter Ling in one of the first studies on buprenorphine and detox, he had said that the greatest prognosis of detox alone is relapse, or consistent use of relapse of detox again, or death, if there's not a connected care post-discharge when somebody leaves detox. As we call it now in Connecticut, I don't know if you've changed this vernacular in the language in Nevada, but we actually refer to detox now as withdrawal management. It's less pejorative than detoxification. So that's how we call it in Connecticut. So just want to, I think that's being adopted in other states as well. Next slide, Kim. This might be a double click. So people might be familiar with the Johan Hari. He had this viral video. I actually have him come into Connecticut in November to talk about his new book, The Magic Pill, which is about Ozempic, which ironically, that GLP-1 now is being used in all the clinical trials or being reviewed for NIDA to actually look at the reducing of craving for alcohol, tobacco, opiate stimulants, and any other substance. And it makes sense, right? If you can lower the tone for craving and for food, why wouldn't it work with other substances? So I only say that because Johan Hari has the quote on the bottom that the opposite of addiction is not sobriety. The opposite of addiction is connection. And oftentimes the first opportunity for connection is detox. And we miss that opportunity so often. It took us a while to finally put recovery coaches in our detoxification center and family recovery coaches, because as people are probably aware, and I think Marcy, I get some nods there, so that's a good sign. The family gets ignored, and the family oftentimes isn't an action stage. If you're familiar with the stages of change, Prochaska and DiClementi's model, oftentimes the family is in the stage of action and willing to do whatever it takes. And sadly, most people come in, even that 10% that I referred to that come into treatment, they've got external pressure. They're either mandated or mom-dated, right? So they even have, it's either their family or some other force. And most of the work we try to do is to move them towards a stage of readiness to at least be contemplative to get to action stage by the time they leave us, so they can actually see that they may have a problem. It's hurt themselves, their loved ones, and now they're willing to do whatever it takes. I think our treatment system is pretty flawed because it still is really predicated on the fact that people are coming in willing to do whatever it takes and ignoring the fact that they are really coming in with a gun to their head, which means you're not getting internal change. What you're getting instead is compliance. And I only bring this up because that is dangerous to have compliance, because now that individual, because their family wants them to come in, is going to do what they need to do to get their family to not worry about them anymore, whether it's a formal or informal intervention. So they'll go through the detox, they'll go through treatment, even a 30-day treatment that we found in the study, but they're only being compliant So without that buy-in, they're actually at greater risk because now they've had no tolerance for their substance of choice, particularly with opiates. They're at great risk of overdose. And I think more importantly, because they don't want to disappoint their sponsor, their recovery coach, their counselor, their family members, or whoever drove them to treatment, they're going to relapse in shame, and they're going to relapse in private, and most likely at home, most likely without Narcan around or somebody to revive them. So that's what puts them at greatest risk. So, this is from initially from Nora Volkov's work with NIDA, which is just a great summary, I think, from a brain chemistry standpoint, that people do drugs for two reasons. And if we one more click, there you go, Kim, it's all about connection, to feel good or feel better. People come into my agency not usually because they're feeling good and it's all about sharing experiences and substances. They've come in, they may have started that way, but most of them are self-medicating other issues, usually trauma, anxiety, depression. And it's really important to note that, because it really it changes the mindset in working with people, because I think we assume a level of what they call recovery capital when people come in. But if people have been traumatized and their world isn't safe yet, then it's not safe to connect. It's not safe to love. It's not safe to be that vulnerable. And it's unreasonable for us as a treatment system to expect that. And that's why we get compliance instead of real change. And that's why we've shifted our system of care in Connecticut to be more harm reduction focused. And I've been involved in this group called Connecticut Communities of Addiction Recovery, and they were one of the pioneers in the recovery coach movement. They actually do the curriculum for most states, and they always talk about meeting people where they are. If you meet people where they are, that's great. But it really wasn't meeting people where they are. It was meeting people where we wanted, where they were, with our agenda to get them into recovery, and then offer them pathways, mostly abstinence-based pathways. So my recovery coaches on my staff ask two eloquent questions. If somebody is ready for recovery, and we meet them at the detox or withdrawal management, or we work with hospitals or in the community, we say, how can we help you in your recovery today? That's what the recovery coach says. And what does your recovery look like to you? Now, we've shifted that to expand to the other 9 out of 10 individuals that aren't interested in recovery, and we meet them where they are, whether it's in the emergency department or wherever they are, and they're not interested in recovery. So we basically ask them, again, meet them where they are without our agenda. What does help look like to you, right? And how can we be helpful? And what does that look like to you, to really personalize it and tailor to somebody? It might mean housing. If they're unhoused, it might mean, where they get their next meal or a job. So we try to really do that in a new way, and it kind of expands the whole way we address it. And when we talk to staff about it, it's really simple to kind of, from a supervision standpoint, if the staff walks away frustrated and in supervision is angry or upset at a client, they haven't met them where they are. They had an expectation of where they wanted that client to be to make them look good or have some guru complex or whatever, versus really being able to meet them where they are. If you meet people where they are, and by the way, this can save you thousands of dollars in couples therapy, because I'm a licensed family therapist by trade. If you meet your partner where they are, you always walk away with new understanding, love, and compassion. If you walk away with anger, frustration, or anything else, it's just like any other human being. It's your issue, not theirs. Okay, next slide, Kim. I'm on a roll. So I just emphasize, this comes from Tom McClellan's work. This is really sad. These are the numbers, with 25 million people that could benefit from treatment that would meet diagnostic criteria for substance use disorder, but 2.3 million people are presently in treatment in 2025. So again, 10%, and even in that 10%, many mandated and mom-dated. Let's try to keep that 90% alive till the miracle happens, recognizing 2025 may not be the year of recovery for somebody. So then again, it's all about, that process of engagement. And we don't even know who is harmfully involved that could benefit from one or, even a minor intervention. Next slide, Kim. I put this in there just because I emphasized earlier, this is I think our system floor. If people ever took a psychology class, they know of Maslow's hierarchy of needs. How are we expecting people to be self-actualized and connect and feel lovable, capable, and connected if they aren't physically safe, if they don't have their psychological and sense of belonging and a sense of worth met? So I just say that because I think we have to cut off this triangle to actually start to have that be a reasonable place to start a conversation for full abstinence. And until we can meet their primary basic needs, we're just foolish and wasting our time and actually causing them more shame, more hurt, having them feel like it's their problem, and shame on us. It's our problem. There's no such thing as a resistive client. There's only a system and an individual or a counselor recovery coach who's resistive to pay attention to what that person needs in the moment. Next slide, Kim. So I'm on the Governor's Task Force for Alcohol and Drug Policy Council. We actually put infused in our practices and principles, meeting people where they are, and we've adopted harm reduction principles in all the treatment programs now. But again, it's a process, and not everybody's on board on the same page, but we're moving in that direction. Next slide, Kim. Now, this is the crux of what you really need to look at. That's the wake-up call. That was the most disturbing first do no harm research study I've ever seen, which is this research study that I referenced before, that at the end of the study, for people with opiate use disorder in 2016 and 17 and a 6-month exposure to treatment, if the person was exposed to methadone, they actually decreased their likelihood by 38% of a likelihood to die. Buprenorphine, 34%. However, if they were exposed to a 30-day abstinence-based program or detox alone, it increased their likelihood that they were going to die by 70% over not having gone treatment at all. So if they stayed out on the streets and continued to use, they actually reduced their likelihood to die than if they went into detox. So that's for your committee to decide what you're going to do in Nevada. But this is a wake-up call. And my belief would be, if you don't have a good engagement specialist, recovery coach, outreach specialist, harm reductionist in your withdrawal management detox centers and not connecting them to a pathway of recovery when they leave, shame on you. You're causing more harm than good. And it's time to stop that, because it's nothing short of malpractice. Next slide, please. Getting a little passionate here. I'll be kinder, I promise. I'm really a nice guy. I don't mean to sound horrible. I'm just trying to get everyone's attention. So what did we do in response to this? In liberation programs, we developed an informed consent. This is our informed consent that's now been adopted by the Department of Mental Health and Addiction Services in Connecticut to recognize that those individuals, when they leave detox now in Connecticut, everyone gets Narcan. Everyone gets this informed consent to let them know that we recognize that medication-assisted treatment is the gold standard, and that medications are the gold standard, and counseling behavioral therapies may be an important part of that. However, we emphasize that medication alone can be effective because it, again, it quiets the brain until a miracle happens. And these medications are not a cure, but they've been proven to be safe and prevent withdrawal symptoms that, again, doesn't get them distracted out there when they address the community, people, places, and things. Next slide, Kim. And it continues into having them really agree on that. Yeah, I think, yes. So we actually explain all 3 FDA-approved medications for opioid use disorder, which is methadone, buprenorphine, and injectable naltrexone, or any form of naltrexone. And now we even did a study in buprenorphine where the RDD study with NIDA, so we actually even include Brixadi, which is a new injectable form of buprenorphine. Next slide. So we have them sign that at the end to let them know what the risks and benefits are of the medication, but most importantly, the risks and benefits of not being on that medication by referencing that study even. And so then the person can also, when they leave, everybody gets the important message that Narcan is life-saving, and everybody leaves our detoxes, withdrawal management, and residential programs with Narcan. Next slide. So again, it's a philosophy standpoint. It's like meeting people where they are about, really being able to treat everyone with dignity and respect, even if they've come through, detoxes 5, 10, 20 times. It doesn't mean this year is going to do it. My chief clinical officer, who's with me here today, I'm actually, and that's why I'm in a hotel room. I'm in Denver at the Science of Psychedelic International Conference here in Denver. And my chief recovery officer, who actually, is a licensed social worker, will be the first to tell you that she took her 24 times to get through 24 detoxes until she was ready to turn her life around in recovery. And she leads with that, not her credentials, but the fact that, sometimes relapse is part of recovery. So never give up on people, because she's grateful nobody gave up on her. So at the end of the day, it's more important to show people how much you care before you show them how much you know. Next slide, Kim. And then people talk about harm reduction being enabling and having people going through detox and withdrawal management more than once. Is that enabling? Enabling is such a load of crap as a concept. Tough love, by the way, mutually exclusive concepts. You got tough and they got love, but they never should be in the same sentence, right? It usually people feel it more as abandonment and betrayal. So everybody shows love the best way they know how. And it's usually more for the family than it is for the individual, because we know it's not as effective, especially it's like half as effective as a community, the craft model. But you want to have every family member realign their relationships and redefine their relationships in a manner that recognizes that their recovery process and their healing is separate from their loved ones, right? And the more you show you're humanness, the more you're lovable. We don't have time to get into that. And again, as I said, it's more important to show people how much you care before you show them how much you know. And if you want to look at mental health with all the co-occurring issues in a nutshell, it's moving people towards feeling lovable, capable, connected. And that's all I got. Next slide, Kim. I think that's it.
That is the last slide.
That's it. Any questions? Hopefully this was helpful. That's 40 years in the field of addiction treatment in a nutshell, which is really sad because you'd think I'd have more to say.
Mr. Hamilton, thank you so much for your presentation. Before I open it up to questions, I just wanted to ask if you could touch briefly on the collection of data.
The collection of data, we have a thing called a DDAP system in Connecticut, which is every licensed nonprofit, not the for-profits, but the nonprofits, anyone that takes Medicaid, and now we have an SUD waiver, so when everyone has to do it, all levels of care through the ACAM criteria, from outpatient to residential to detoxes, methadone and hospital-based or community-based detoxes, all have to collect data, admission data and discharge criteria. And we actually have this administrative service organization that tracks everybody on Medicaid for all of their connected care rates. And so they are actually tracking everyone that comes out of detox to see what happens to them. And they have the abysmal data of what happens to the person and how they continue to utilize detoxes in the system again if they're not connected to the next level of care.
Great. Thank you so much. I just wanted to bring that up because I think that's going to be really critical if we move our recommendation forward to figure out how we're going to be able to gather, and analyze that data in our state.
Do you have a administrative service organization that tracks Medicaid utilization? Because that was a great place where we started.
We do, and I'm forgetting off the top of my head who that is. Kim may know, but there is an ASO in place as far as I know.
Yeah, I don't know off the top of my head.
But good point, Mr. Hamilton. Thank you, Kim. I wanted to open it up to questions from our subcommittee members. If any of our members would like to have any questions or make any comments.
Nothing here. Thank you so much for sharing the information.
You're welcome. Any way I can be helpful in the future, Kim has my contact information, and you're all welcome to come to Connecticut and see how we can collect data, or we'll send you whatever you need to be helpful.
We appreciate that. Any other questions or comments from our members? Okay, hearing that, Mr. Hamilton, we really appreciate your time today. And thank you so much for your great presentation. And we look forward to seeing you again in the future. So thank you again for making time to be here today.
It was my pleasure. Thank you all. Have a good day.
Thank you.
Take care. Bye now.
Thank you. For our members to know, before we move on to our next agenda item, we do have the option under this agenda item to take action on this proposed recommendation. We can have a discussion regarding adopting this recommendation to move forward in the process and having this as one of our recommendations to the full SURG, or we can hold on this until we hear other recommendations in subsequent meetings. So I just wanted to put that on the table. If any of our members are inclined to take any action about this proposed recommendation, we certainly can consider that. So on that note, does anyone have any comments or any inclination to make a motion?
Could you go back to the recommendation?
Yes, I'll go back to it now. And you will see it on a subsequent slide, but just to note, Chair Shell, the subsequent slide is not agendized for possible action.
Okay, thank you.
Can I ask a question as a newbie here?
Oh, yes, Assemblymember Golden, please.
So with the recommendations, do we delve into the cost of recommendation or the mechanics of the recommendation, or is it the subcommittee's responsibility to put forward a recommendation like this, and then subsequent steps would be, okay, what would that assessment look like? How to roll that out? What are the costs associated with it? What are the objectives of it?
Yes, Assemblymember Golden, I would say all of the above. We can certainly, review all of the mechanics and any potential costs related to the recommendation before we actually submit it to the full surge.
So
That's what
this,
we've done with our previous recommendations.
okay, so this recommendation is very high level and it doesn't include any of those details. So at this point, if we voted on this recommendation, would we pursue additional levels of detail before we pass this on to the surge at large?
Yeah, absolutely. We can ask for additional presentations from subject matter experts. We can have additional discussion around this. We can think a little bit about this and bring it back to our next meeting if we would like. So we have several options available.
Thank you for that.
And we actually, Kim, if you'll refresh my memory, just for the assembly member to be aware, when is the final due date of each subcommittee having their recommendations being ready to present to the full surge?
So that is a little in flux with, as we'll see on the following agenda item, with the passage of AB 19 in this last legislative session. So I would probably defer to Dr. Kearns, who's also on the line, if she wanted to weigh in on that, on what we're looking at potentially for time frame. But it's, as I noted, it's a bit in flux.
Chair Shell, if I may.
Yes, Dr. Kearns, hello.
Yeah, thank you, Terry Kearns, for the record. So as I think most of you know, in our last recommendations, AG Ford pushed forward a bill draft request. It was AB 19 to, first of all, increase the membership of the surge, and some changes and things were added in that as it went through both Assembly and the Senate side. And AB 19 has been signed off by the governor. And part of that was to add the members. But the other part of it was through some discussion about how can we make our recommendations a little more actionable? Because I know at least the response and prevention subcommittee had recommendations that were too late to get into BDRs. So as part of this, what we decided is to change the date that the recommendations would come out. So we'll have, as you know, our previous recommendations came out in the annual report, and it was due the end of January. So we will do an annual report at the end of January in 2026, but we won't have finalized recommendations. That will move now till August of every year, and the recommendations and the annual report. So our recommendations, I guess for this year, will now be due in August of 2026. So we'll have a little bit more time to work them. So, and also I wanted to just let Assembly person Golding know that there is a form that SEI provides, and it gets into some of the detail that you were talking about, which of the special populations would we be looking at, and which of the mandates that we were provided under the original legislation that started the surge, which would those touch? Also, is there a financial note to it? So it gets into a lot more of the detail, and that is something that I know in some of the other committees, they just come forward with an idea and it gets kind of workshopped as part of the committee's work. So hopefully that helps.
Thank you. I appreciate that.
Yeah, thank you, Dr. Kearns. And I wanted to mention as well that Ms. Cheatham is not with us today. She is our subcommittee member who actually made this proposed recommendation. And so hopefully she'll be able to attend our next meeting and can share, enlighten us more on what her thoughts were on all of this. And also regarding some of the information Dr. Kearns just mentioned that is actually listed on the recommendation form. So I think it'll be helpful to have Chelsea with us for a subsequent discussion. And then we as a group can decide what additional information we may need before we decide if we want to move that recommendation forward. So hopefully that helps. And then I see Dr. Dixon with her hand raised.
Yeah, Dr. Dixon for the record. Well, this is, I've been doing this treatment thing for, in a clinic for, I don't know, since 2008. And I'm always wondering what happens to these patients because, I have a group of very stable patients. Some have been with me almost the whole time. But most of the new patients that I do an intake on, we never see again. And then there's a smaller group that comes a couple times and then we don't see them again. And a lot of them are being referred from a detox. Well, not a lot. A few are being referred from a detox facility. Most have found us through other channels like the internet or something like that. But anyway, it's a big concern. What is happening that they come and then they don't come anymore? And I've been 100% in favor of doing a study like this. But as the Assemblywoman was saying, there's so much detail that has to be worked out. And obviously, you've got to be able to call the patient. And these patients are a bit transient. And what's a good phone number one day is not a good phone number a few days later. And they're very hard to track. But if we could get them to be really educated about how important it is to keep in touch or let us be able to keep in touch, it would really help. But it really is going to require probably some grant money and some research assistance to do the work.
Yeah, thank you, Dr. Dixon, for making that great point about being able to track these individuals. I'll share in a coming agenda item a recommendation that I'm making regarding peer support teams that I think would be able to help track these individuals and then be able to help us collect that data. But I appreciate you bringing that up, Dr. Dixon. Any other questions or comments from our subcommittee members? Okay, hearing none, we will move forward in our agenda to item number 5. This is for possible action. This is a review of the progress on our prior SURG subcommittee recommendations. I know many of us have expressed wanting to know more about the progress of the recommendations that we've made, as well as our other subcommittees. And I know Ms. Hale, who's with us today, has done a great job of developing a tracking sheet. So I will turn it over to Laura. Hello, Laura.
Hello, Chair Shell, thank you. Just to clarify, there are 2 different types of reports that I have been sharing with SURG members. One is a progress report on recommendations that is looking back over the past few years, and a lot of that information comes from the Department of Health and Human Services. This particular tracker is a little bit different. This is specific to the bills that were in the recent legislative session. And so at the last meeting, we talked about those SURG recommendations and those updates. This one is to talk about bill status. There is some overlap sometimes. So sometimes there are bills that also relate to a specific recommendation. These bills more generally can be anything that might be relevant to SURG, whether it's based on a recommendation or whether it is based on the original legislation for the scope that the SURG can look at and try to address. So we'll just kind of go through these. And these also are across all of the SURG, not specific necessarily to treatment and recovery. So the first one, AB6, the governor has approved that one. And the connection is that it had establishes the FASD fetal alcohol syndrome treatment assistance program. And the relevance to the SURG you'll see in the 3rd column over. 2023 and 2024 recommendations include tracking data for alcohol use and outlet density. That was a particular recommendation from the prevention subcommittee. And then also Medicaid had reported to the SURG on implementation of a health home for individuals with FASD. The next one down is AB 19, and that was the one that Dr. Kearns just talked about, changing the annual reporting. And as she mentioned also, the governor has approved that. AB 31, the next one down, provides for certain Medicaid reimbursement of providers of non-emergency secure behavioral health transport services. This one did not get any further. It had gone through some of the committee hearings, but as of sine die, there was no further action on that one. AB 60 revises provisions relating to certain behavioral health services. Let's see. So there are multiple effective dates on this. The governor has approved it, but there are different pieces. The relevance to the SURG, the recommendations include amendments to NRS pertaining to hiring and regulation of peer recovery support specialists and incorporation of peer recovery support specialists into treatment models for emergency departments. And then there were also some recommendations related to this in 2023. So onto AB 340, the next one down. That one also did not get any further action, but might be something that you'd want to look at again in the future. Going down to the next page. Thank you, Kim. AB 378 creates the alternative therapy pilot program. That one also did not make it past sine die. AB 380, the governor has approved, and the effective date on that one is October 1st of this year. And it relates, there was a 2023 recommendation to expand access to MAT and recovery support. So this particular bill revises the composition of the mobile crisis team with one or more persons who are professionally qualified in the field of behavioral health, one or more law enforcement officers, providers of emergency medical services, or persons with appropriate expertise in the field of behavioral health, such as a community health worker, provider of case management services, provider of peer recovery support services, or a similar paraprofessional. And then down to AB 394. This one the governor has approved, and that was effective upon approval. Relates to our 2024 recommendation to ensure opioid antagonists must be available on all campuses. And this, you'll remember, was presented by your subcommittee member and SURG member, Dorothy Edwards, sorry. I'm sure you'll all be thrilled to see that one go through. That was part of your recommendations to make that available on campuses. And then SB 118, no further action on that one, had to do with the State Board of Pharmacy. So we'll move down to the next page. SB 192, no further action on that one. It would have prescribed certain requirements governing dispensing of a controlled substance listed in Schedule 2, 3, or 4 for the treatment of pain. And there were specific implications for different sections of that bill that related to the SURG requirement under AB 374, Section 10 on the prescription of controlled substances. SB 300 makes revisions to relating to Medicaid. The governor did approve this one, and it relates to the SURG Medicaid coverage of behavioral health services, support treatment and recovery for many of the SURG target populations. And so this bill codifies into law existing requirements that Medicaid would cover services provided by a psychiatrist, psychologist, advanced practice registered nurse, MFT, licensed clinical social worker, at a federally qualified health center. So it is specific to that type of care provider, and then newly requires Medicaid to cover services provided by a mental health counselor. The next one, SB 337, revises provisions relating to opioids. That one, no further action. SB 353, the governor did approve, and that was effective June 6th. And Section 1 of the bill requires the Division of Healthcare Finance and Policy of the department to establish a specific category of provider for the purposes of billing and reimbursement under Medicaid for certain clinics that provide education and training to students of certain mental health professions, and all-inclusive per diem rates of reimbursement under Medicaid for services provided by a trainee during a visit to such a clinic. And I think most of you know that there were bills in the works to break out the Medicaid division, and two of those. So you can see that this particular element was approved by the governor, but wherever Medicaid resides, that would carry forward. So even if there's a change in the future, they would still have this requirement. And then, do we have a couple more in the, yeah. So SB 457, no further action on this one, but I did see an article that it is expected to reemerge if a special session is scheduled related to the federal budget cuts. So this was the governor's bill. This was the crime bill. And there was a section, Section 73 was in there to make changes to establish the crimes of trafficking, mid-level trafficking, and high-level trafficking of certain substances. And so that was something that was among the SURG's very first recommendations to decrease some of those trafficking weights. And it was before Sine died, that section was amended out of this bill by the governor. So even if this reemerges, if there's a special session later this year related to budget issues, it seems likely that the governor would not refresh that particular element, but he certainly could have that option. So something to keep your eye on if that bill comes back up again. And then SB 494, governor approved on June 10th. Oh yeah, so here's the one that I mentioned earlier that eliminates DHCFAP, the Division of Healthcare Finance and Policy, and moves Medicaid, PEB, and other functions to the Nevada Health Authority as a new executive department. And there's quite a lot of detail to this, so you can always go back and listen to hearings on any of these bills. SB 495, no further action on that one. This was kind of a companion to SB 494. So again, it might come back up at a later date. So I would say just keep your eyes and ears open. And again, you can go back and listen to hearings if you want to know some of the details of what they're trying to do. It's pretty extensive. It's a major change under the State Division of Health and Human Services, but it was something that the department was supporting and gave in detail testimony on. And that's, I think, the end.
Laura, thank you so much. This is extremely thorough, and it just really highlights the great work that our legislators did during this session, along with Governor Lombardo supporting and then signing into law. So we really appreciate that update. I see Dr. Dixon has her hand raised.
Yeah, Dr. Dixon, for the record, I want to go back to SB 300, which we discussed in last month's meeting. Mr. Firestone brought this up, and we talk about it, and so I was watching it very carefully. This is the one that's going to increase the amount of money we get paid per patient per visit in the methadone clinics. And we're very excited that you have to do a little searching to see that part in the bill, but actually you see it in the exhibits. But we were real excited about that because as reading the minutes from last month's meeting, the payment for methadone had not been increased since the 1980s. And so this was the first increase, and it might make it, more feasible to keep these clinics open with a little bit better payment. The only big problem is how many of our patients are going to lose their Medicaid as the big beautiful bill goes through. I read today that the Senate wants to even may cut out more patients off of Medicaid. So
That's correct, Dr. Dixon. I read the same thing earlier today. So you're right. I think that's something we all need to keep on our radar. We've made great progress with a lot of these policy and reimbursement changes with Medicaid, but a lot of it, certainly will be on the fence depending on what happens at the federal level. So thank you. And I do know Mr. Firestone is very pleased that the governor did sign that bill. So that was a great presentation from him in our last meeting. So we're glad to see that legislation moved forward. So thank you, Dr. Dixon. I know Dorothy Edwards also wanted to make a comment or has a question.
Yes, thank you, Chair. I wasn't able to find my little hand raise icon. Dorothy Edwards, for the record, the Washoe. I also represent the Washoe Regional Behavioral Health Policy Board. I'm the coordinator. And so just because I have been kind of updating you on some of the policy board bills, Laura, this is excellent. I've already sent you an email asking you to send me a copy. So I can cross-reference my own. But I had brought up a few, at least 4 of the bills that had been brought forward by the regional behavioral health policy boards. We were glad to see that at least one, and Ms. Hale mentioned it, AB 60 that passed, and that is the Northern Policy Board bill. So we were happy to see that. You mentioned AB 31, which you're so much more polite. I just have this big red failed on my spreadsheet. You're like, no further action. But it was the Southern Board bill, and that was the transportation. We thought that had a chance. Then our bill, my bill, I have just great ownership, SB 47. That was the Washoe Regional Behavioral Health Policy Board. It's not on this sheet, but that did not go any further. It failed, and it was addressing the parity. If you'll remember, I talked a little bit about that, proposing a study on the parity within Nevada, and that didn't go anywhere. The good news is that AB 207, if you want to look that up, that also addressed parity. That was put forth by Nevada Psychological Association.
That's correct, Dorothy. Yes.
Yeah. That did pass, and so that is good. However, good news, bad news. We read a couple weeks ago, at least I sent it to the board, that there is a proposal at the federal level to stop the recent upgrade or improvement or addition to the federal parity law. So that's sad. So we'll see if that goes through. Then maybe some of our work will be for naught, but we were happy to see that. And then the 4th policy board bill was SB 60. Really thought that might have a chance. That was the rural regions policy bill, and perhaps not as germane to our group, although I think you could argue anything with behavioral health is germane. That was the social work compact for social workers. And so I don't think any of the bills that had to do with compacts, interstate compacts and that sort of thing went through. I could be wrong, but didn't mean to jump on Laura's presentation, but just because in the past few months I've been reporting out on those, I wanted to follow through. So thanks, Chair, and everyone.
Thank you, Dorothy. Anyone else wishing to make a comment or has a question?
I just
Oh, yes, Laura, go ahead.
Sorry, Chair Shell. This document is on the AG's website now, so anybody can pull that down. But for Ms. Edwards, thank you so much for adding those. I should have compared notes with you earlier and be happy to send you the my original document if you want to, go through and edit that or add notes or whatever you'd like.
That'd be fabulous. I so appreciate yours is so much prettier than mine.
Thank you.
Well, Laura, thank you so much for this excellent review. I think this helps all of us tremendously. So I would encourage all of our subcommittee members to go back and review this in more detail at your leisure. But this is very helpful for us all to understand, to be aware of what actually moved forward. And it also gives us an idea of what didn't move forward as to what we may want to consider for our subcommittee or for the full SURG. So thank you so much, Laura.
You're very welcome.
Okay, we'll move on to item number 6 in our agenda. This is for discussion only. This is to discuss the 2025 Treatment and Recovery Subcommittee recommendations process and any proposed recommendations. As Dr. Kearns alluded to a few minutes ago, it sounds like we have a new process for actually submitting those recommendations. Not a new process, but a new timeline for submitting those recommendations. We do want to encourage all of our subcommittee members to submit any recommendations you have via the SurveyMonkey. Kim, I don't know if you want to add any more to that.
No, just a few things, I think, especially because we have our new member, Assembly Member Goulding on the phone today. I wanted to just note that SurveyMonkey, we'll go ahead and send that out again. Since that is only open to the subcommittee members to participate in, we will email it to you, the link to you directly. One thing to note is it's quite a hefty survey that we ask you to complete, and you will get locked out of moving from question to question if you don't put in something. So if you have a recommendation and you think, I am not quite ready to fill this out completely, or I don't have the answers to all of these questions yet, just do something in the box to put in an asterisk, put a note that says more to come, or call me, let's talk about it, put in any of that, and that will help you move through the survey and get it submitted. And then the SEI team can follow up with you to help you refine or gather additional information as needed to support your survey. What we ultimately do is anything that is included on that SurveyMonkey, kind of the final version of it, does end up with the recommendation in the annual report as backup. So that is all made public as well and published. So we like to make sure that that's as comprehensive as possible. So yeah, just a note, no worries about an asterisk, a note, anything like that, just to help you move through the survey.
Great, thank you, Kim. And then we just wanted to remind all of our subcommittee members that we really would encourage you to submit at least one recommendation. I know at this point, as of yesterday, we had one recommendation already submitted by Chelsea Cheatham. I submitted my recommendation late yesterday evening and just wanted to give you a quick overview of that. But I don't think we have any other recommendations at this point. Is that correct, Kim?
Correct. And I'll note the only one I've incorporated in the PowerPoint, because I didn't actually catch that yours had come in yesterday, I apologize, is Member Cheatham's. And so, but I think you're prepared to maybe talk about yours verbally.
Yes, thank you so much, Kim. Yeah, I just wanted to give everybody just a quick overview of what I would have proposed and what we can certainly discuss in a subsequent meeting with possibly bringing in some potential speakers. But I would love to see hospitals around our state incentivized to establish peer support teams in their emergency rooms. I don't think hospitals are thinking enough about this. One of the reasons why a lot of hospitals have not moved in this direction is due to the lack of financial resources and due to the fact that most payers do not reimburse for those types of services, unfortunately. So I would love to see us make a recommendation to the SURG and beyond that some of our opioid settlement dollars be allocated to hospitals around the state to create peer support teams who would meet these individuals, in the emergency room when they arrive as a result of an overdose or another reason related to their substance use, but then also maintain communication with those individuals once they leave the emergency room and track those individuals for an indefinite period of time to ensure that they're maintaining their follow-up appointments, that they're avoiding visits to the ER that may not be necessary, and make sure that they're maintaining their recovery. And we do have the FRN funds that are available through the state of Nevada that hospitals can certainly tap into. Those are the Foundation for a Resilient Nevada funds that are based on the opioid settlement dollars. But I don't think a lot of hospitals are thinking about peer support teams. And I think if there was a way to heighten awareness around that, we might see more hospitals willing to go down that path. And as Mr. Hamilton mentioned earlier, as well as Dr. Dixon has always said to us, we have to meet patients where they are. And I just don't think we're being effective when these patients land in the emergency rooms. And that's why we see a lot of them returning, for multiple visits through the year. So that's my recommendation. I did note, Kim, a couple of speakers that I think might help us in this area. I'm certainly open to any other thoughts, but I did list CASAT at University of Nevada, Reno, as well as, and I'm forgetting the other one, Kim. I had a second one. It will come to me, but I had two that I listed in my actual recommendation, but I was also going to add Track B as another potential speaker on this matter. I know that they've actually established peer support teams. We actually had them in the emergency rooms in Reno for about a year or so, and then had to dissolve the team due to a lack of funding. So there are a variety of speakers that we could certainly bring in on this topic. I see Dr. Dixon with her hand raised.
Well, in regards to the speakers and last month's minutes, we were, it said that Dr. Kamyar couldn't come last month because the date changed and he was going to come today. What happened to Dr. Kamyar?
Yes, I'm glad you brought that up, Dr. Dixon. Kim, I'll turn that over to you.
Yeah, unfortunately, there was another scheduling conflict that occurred. So we did reach out to Dr. Kamyar, and they unfortunately were not able to attend today. So we're going to do our best to get that scheduled for the August meeting as well. So it may be that the August meeting has several speakers, Chair Shell, if we're able to do some follow-up with the folks that you're recommending.
Okay.
And I am opening the survey now. So if you'd like me to tell you the other person you recommended as a speaker, I'm happy to do that.
It just came to me, Kim, but I'll let you go ahead.
Oh, no, go ahead if you've got it, because I haven't.
Okay, yes, I finally thought of it. I also suggested Foundation for Recovery with Sean Hampton and his team. They've done a lot of work in the peer support space, and I think it would be helpful to have him come in and talk about establishing teams, particularly in emergency rooms, and what that means, what that would entail. But certainly open to any other subject matter experts in this area, and certainly open to any discussion about this recommendation as well. We can certainly discuss it in more detail in a future meeting. Yes, Dr. Dixon.
Well, it's unfortunate that our member, Mr. Iverson, isn't on this call and he misses some. But Crossroads is probably the biggest detox facility right now in Las Vegas area. And they have one of the doctors I used to work with left our place and went over to be the medical director there, Dr. McSwain. And I know one of our graduating fellows has been working with them on trying to get a better discharge planning, getting people into treatment, which was never big with them before. Once they left, they have a lot of outpatient, intensive outpatient stuff, but medication assisted treatment, they were not referring to much, and now they're improving. So it might be worth having them come and talk to us more about how things are changing if we're getting more people into treatment, medication treatment after they leave detox, or what did he say we call it now? Anyway, so I'd like to hear more from in other words, I'd like to have Crossroads come and talk about Crossroads.
That sounds great, Dr. Dixon. We can certainly have Kim and the SEI team follow up on that. As you said, Dr. Dixon, they've done a lot of great work in Las Vegas and have rapidly grown through the years. So I would love to hear more about that myself. So thank you for bringing that up. And
then I think I've read recently that WestCare may be reopening their detox part of their facility. I'm not sure how they managed it, but maybe it's partly due to the increased revenues from the new bill. We'll see. But anyway, that would be another thought, to have some folks from WestCare talk to us.
Yeah, I've heard that as well, Dr. Dixon, about WestCare, and would like to know more about that as well. So thank you. And then just to note for everyone, if you have any other recommendations for speakers, you can email Kim Hopkinson at any time and make her aware of your recommendation for a speaker for a future meeting. And at the bottom of the slide there, you'll also see our upcoming subcommittee meeting dates. Just wanted to remind everyone, our next meeting is on August 19th at 3 o'clock. And then it's not on the slide, but our full SURG meeting is coming up next on July 9th at 2 p.m. So that's just another friendly reminder of that meeting as well. Any other discussion on item number 6 of our agenda? Again, just to close out this agenda item by encouraging all of our subcommittee members to really give a lot of thought to any recommendations that you could bring forward to our subcommittee for discussion would be greatly appreciated. Okay, that will conclude item number 6. We will move on to item number 7 again, which is public comment. This is discussion only. I'll just make a brief statement. Public comment shall be limited to 3 minutes per person. Members of the public may comment on any matter that is not, may not comment on any matter that is not specifically included on the agenda at this time. However, no action may be taken upon a matter raised under this item of the agenda until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to subparagraph 2 of NRS 241010. So on that note, I will open it up to public comment. And I see Dr. Kearns with her hand raised.
Thank you, Chair Shell. Terry Kearns for the record. I just wanted to let the subcommittee members and others know that the Southern Nevada Substance Misuse and Opioid Prevention Summit will be held on August 19th. There is a minimal registration fee of $25, but there's also lots of scholarships to go to that as well. And so that would cover the cost of the registration, but not travel. So I'm happy to provide the information for the registration and for the scholarships to Kim that she can provide.
Great. Thank you, Dr. Kearns. Do we have anyone else wishing to make public comment?
I do not.
Okay, hearing none, that will conclude item number 7. Item number 8 is our adjournment. Before we adjourn, again, just a friendly reminder that our full SURG meeting is on July 9th at 2 p.m. So we hope everyone will attend that meeting. And then our next subcommittee meeting will be held on August 19th at 3 p.m. So in the meantime, please take care, and we'll look forward to seeing everyone soon. Thank you all for being here today.
Aye.
So much.
Thank you all.